Okay, this is kind of an interesting case. 1998, your favorite kind of mammogram, Bill.
Yeah, I usually take these off the view box and put them in Hilda's stack
Yeah,
of
that's
films.
what you did, I'm sure. That's what I'm sure.
Well, I'm a little worried about the subareolar area on the right breast, and the posterior glandular margin, maybe.
Yeah, back on the right.
On the right.
Yeah, let's it'll back in there.
Back in there.
Yeah. Well, that was ignored, so we don't know. But absolutely, I mean, it looks funny compared to the other side of something in the retroglandular space. Everything was ignored here, and here's the other view, the MLO view.
Well, it's very easy to get lulled on the MLO because you can cover up the retroglandular space that you see on the CC view, but I would put the area that we saw on the CC view in here, and it's a little funky. The tendency is to say, well, I don't see anything on the back edge of this, but it's rolled now into this.
Right, well, this was also summarily ignored. So we'll go to 1999 and see what happened. This is the CC view, and here's the MLO view.
Well, yeah, again, you can be lulled into thinking there hasn't been much change, but maybe this little guy right here has some speculation around it.
Yeah. Here's the 98 view just for comparison, the MLO, and there's the area you're talking about, Bill.
Yeah.
And here's the one in 98. Yeah, it looks like there's been a little change there. I would say at the very least we have to have some level of suspicion. Again, this was summarily ignored. And the main reason for that, I'm sure, is the fact that there really wasn't anything on the CC view that correlated exactly. So as a result, this was dismissed because it was sort of a one-view finding, if you will. So then we go on to, this is 99. I'm sorry, this is the 99 compared to the 98 and the CC. And you're right, that area in the retroglandular space still looks a little funny. Doesn't seem to quite match up. And again, it was ignored. So we'll go to 2001. So this is 2 years later. CC and 90-degree view is only on the, CC and MLO on the right only. We'll ignore the left breast. We'll assume there's nothing in there.
Well, again, you could be lulled into thinking it hasn't changed or even looks a little bit less concerning, but it's still there.
Oops, I'm sorry. Yeah, and here's the CC view on from 99 compared to 2001. Again, if anything, that retroglandular thing on the right is disappearing. Doesn't look so bad. But when you look at the 99 compared to 2001, in that area you were commenting on, it looks about the same, maybe even a little less dense. So again, one view finding, even though there's architectural distortion, it appears, or something going on there, it was ignored. And so we go to 2002. At this point in time, what do you think?
Well, whatever she's got, it's still there.
It's still there. That's right. But at this point, let me tell you that one of my partners said, there's something going on there. So they did work it up. Here's the CC spot view. Not much. Not much.
Yeah.
And we looked around and did several other CC spots, nothing exciting. But here's the MLO spot. What do you think of this area, Bill?
Well, I think that has some converging lines and some speculation, and it beginning to look like real architectural distortion.
Yeah, I mean, looking at this retrospectively, I think it's real easy to say that, and you're absolutely right. Prospectively, this is one of the best guys in my group, and for some reason, he just said, normal. No ultrasound, no nothing, just come back in a year. So went merrily on our way to 2003. Now what do you think?
Well, now we're pulling in more converging lines, and the spicules are becoming more prominent and clearly more sinister.
Here's 2002, just for comparison. Yeah, if anything, maybe, but again, this was read as no change, ergo it must be normal. So we go to 2004, and now what do you think?
Well, now I think it'd be a good idea to biopsy her about 4 years ago.
Yeah, too late for that, Bill. But we got to deal with the present. Here it is. And now, still don't really see it well on the CC view, do we? So let's do some coned views again. Now, here's the MLO view, the cone, and there's no question. What do you think there?
Well, I think it's a bad case of cancer.
Yeah, it's a real bad case of cancer. And here's the 90-degree view, just to show where it was and again how similar it looks to the 60 with the cone view. But now where is it on the more orthogonal views? Let's see if we can find it. Here's the CC spot and a 15-degree view. Anything there?
Well, I have to start looking for where the converging lines are taking me, and the converging lines are taking me into this area and here, and I think most probably into this area.
Well, let me give you a little help here. We're going to do even more magnification of this area and this area, which sort of caught our eye. Here's that area, way lateral, way lateral. And here's this one, which is somewhere between where you saw it on the MLO view and the CC. So it looks as though it has changed dramatically in size and shape, although the spiculations are still there, from the way it looked on the MLO view. So this appeared to be the location of the lesion. So now we know pretty much where it probably is. So what are we going to do? Ultrasound. So let's do an ultrasound. Boom. Just put the transducer there, and like you said, in 2 seconds, you can find this thing because you know exactly where it should be. And there it is. It's at 9 o'clock, 10 centimeters from the nipple, 7.5 millimeter hypoechoic mass with shadowing. 0.75 centimeter, yeah. And here's from the needle oak, you can see that is indeed, we did the needle oak with ultrasound, and then it was indeed that way lateral lesion over there. And here's magnification, you can see it going right through it. And what do you think this showed on specimen? Pretty nasty. So, didn't show up well on one view, did show up well in the other view. Invasive lobular carcinoma, low grade. Interestingly, when we did the MR in this case, the lesion did light up. Here's in the subtraction views, but look at this curve. This is not the really highly malignant curve, which is again something that is characteristic of some invasive lobular carcinomas. It's not a highly benign curve, but it's not one of those up and down. It's one of those intermediate curves. But in any event, it was the only lesion. So the question I have of you, Bill, is what do you think the role of ultrasound and MR should be in the evaluation of architectural distortion, especially if we see it well only in one plane?
I think ultrasound is such an incredibly valuable tool. It not only gives you a chance to see it, but it gives you a chance to feel it. And your fingers will be far superior to the fingers of the surgeon because you've got eyes on the ends of your fingers. And with your fingers, you can find things that you would not otherwise see sonographically, and likewise you can find things or feel things with sonography that you would not otherwise feel without the benefit of sonography.
Yeah, I think really probably more. This should be used more than people are using it now. There's no question. And this is just a nice case just to show you what happens when you let things go if you only see it in one view. Okay.
Okay. Thank you very much.
So,
high-quality breast ultrasound, as you know, is certainly the most useful adjunctive test we have in mammography, or to mammography. It does require, however, the right kind of tools, as Bob Schmidt mentioned yesterday, and as we've been alluding to, you've got to have the right equipment to do this right. It does require a 7.5 megahertz transducer or higher, and there's been some studies to really demonstrate that. This one came out of Europe, showing the difference in the ability to find small cancers or small lesions in general with different size transducers. And you can see with the 5 megahertz transducer, it was a small tumor, it was between less than 0.5 centimeters. Only about 1.4% of these are found with the 5 megahertz as opposed to 40% with the 7.5 and 55% with the 10 megahertz. And it was slightly larger lesions up to 1 centimeter. The 5 megahertz performs rather poorly, only 13.5% versus up to 76% with the 7.5 and the 10 megahertz. So clearly you've got to have the right tools to do this right. It does require an expert sonographer. It really is an art form, as you know. The technologist and or the radiologist should both be bright, experienced, motivated to do this in a way that can produce the rather spectacular results that we all are aware ultrasound is capable of producing. There is an advantage to having the ultrasound done by the technologist. It certainly does save us at least some time initially in evaluating these patients. It does add another perspective. Potentially there will be 4 eyes examining the films rather than 2. There are clear advantages to having the radiologist at least participate at some level in this role. It provides, number one, an incredibly important opportunity for a patient interaction which will result in many times in additional history, which always surprises me. I go in the room, it's like the patient wasn't there when the tech was getting the history. So there is a difference. Certainly, when you come into the room versus the technologist, and it seems to be magical. All of a sudden, the patient opens up and tells you all these things that make a huge difference in what you say and do regarding the case. Another opportunity that it provides is that to palpate the area involved, which can make a huge difference in your ability to identify a lesion. The best opportunity to actually palpate a lesion well is when you've got this goopy stuff all over your fingers. It allows much greater sensitivity than you would ever have otherwise. So for that reason alone, it's probably worth the effort to get involved. There is some bonding that occurs, and I think the more patient interaction we have, the better kind of relationship we have with our patients. They're more likely to come back to see us, and certainly in terms of creating that important bond that exists so that a patient doesn't think that you're just some entity out there who's sending you this huge bill or sending her this huge bill. I think that's really important. And it certainly improves our interventional skills as we get involved with doing the images, and it provides a much better correlation with the mammographic findings. So for all these reasons, we should get involved at least at some level in the examination. I think it's extremely important. I think those of us who don't get involved are missing an incredibly important opportunity. What are the advantages to breast ultrasound? Many of these we're well familiar with. No ionizing radiation. It produces a tomographic image rather than a summation image. There is an accurate, a much more accurate assessment of depth. The number one reason we used to use it, of course, was because we could differentiate cyst from solid. We can find a lesion in dense breast that would otherwise be hidden on mammography. It provides for real-time imaging, which, again, offers us the opportunity not only for diagnosis, but also for intervention. And it's a lot more comfortable on the patient. And probably the most important advantage is that it allows us to make a better decision about the lesion. And this is from the HDI study, the one that Bob Schmidt said was just published, apparently, after all these years. But when you compare this is sort of relative level of suspicion that we have, it's kind of the equivalent of the BI-RAD system, where everything in between is sort of the gray zone. This is very benign. This is very malignant in terms of our feelings about it. And you can see when ultrasound is added to the pot, we're much more able to make a good bipolar decision, either yay or nay, instead of all this gray stuff in between. So ultrasound offers us the opportunity to do that. We know it does it on a daily basis for all of us. The ultrasound image is a two-dimensional representation of spatial and intensity distribution of echoes from tissue interactions with high-frequency sound pulses. The pulses are emitted along an axis. These echoes are then received back into the transducer, which are then converted to voltages, and they're mapped on the image as dots along an axis, with the distance being distributed according to the time lapse that it takes the signal to return to the transducer, and the brightness of the image we see being determined by the amplitude of that signal. So that's how ultrasound works. It works pretty well. but the actual image that we use to make our diagnosis is actually produced more from the artifacts that are produced in this process. And the first three being the major ones, that is enhancement, shadowing, and refraction. That allows us to differentiate the different structures within the breast appropriately. And then these others are things we just have to deal with that we do see every day as well on the image. Enhancement is number one that allows us to make the distinction mainly between cysts and other low-density structures and the surrounding tissue. And this is a large post-traumatic seroma produced from a seatbelt injury. And you can see as this liquefies and has this homogeneous internal liquid structure, the enhancement is merely the fact that the ultrasonic waves as they're coming through are not being absorbed because of the liquid nature of the tissue as compared to the other tissue around it. So it's the lack of absorption producing this relative enhancement of signal. The intensity of the signal is greater here as a result as it returns to the transducer. So that's the basis of the production of the enhancement that we use. Shadowing, on the other hand, is a combination of absorption within this tissue, so the signal never returns to the transducer, reflection of the signal and reflecting back and actually missing the transducer as it reflects back, and refraction, which is the same phenomenon where, especially seen along the edges of masses, where the signal is diverted because the beam is refracted because it exceeds the angle of incidence along these edges and therefore never returns to the transducer to be picked up a signal. So there's a signal void that's produced that we can use to our advantage as shadowing, as we see in so many tumors. There are lots of other things that shadow besides tumors. The nipple complex always is a problem because of the nature of the nipple structure produced and the tissue immediately behind it. So this is something we always have to deal with. Ribs, of course, produce rather intense shadowing, again, because of the complete absorption of the ultrasonic wave. And then, of course, various lesions within the breast, including the real thing. Cancers certainly do this. Scars, unfortunately, do it as well, and can certainly make it difficult to distinguish between the two. Refraction is one phenomenon that we do see also with shadowing, but it can be unique even to cysts. And here you can see where there's signal loss along the edges of the cyst because, again, as the beam hits this curved surface, it is refracted off and never returns to the transducer. So there is, again, a signal void at the edges, even of cysts. So we have to be aware of that. And the one we talked about yesterday that is so frequent is the critical angle shadowing that we see because of Cooper's ligaments. And this is a phenomenon that is not infrequent. As the ligaments approach the skin, again, they have this very steepled appearance. So occasionally, in fact, very often, we exceed that angle of incidence, and we lose, again, the signal. There's this dropout, which can produce rather dramatic images. As several people mentioned yesterday, you can get around this problem by changing the angle of the transducer, or just put the good compression, or a combination. So this artifact can be very impressive, and we have to be very careful as we evaluate the breast not to fall victim to this one particular artifact. Reverberation is one of the phenomena that can occur that we don't really want to see, where you have this production of signal that is produced on an exactly reproducing basis with exact distance from one to the next. It comes from the initial bang off the transducer that the signal can produce. And this is a phenomenon when we see these repeating lines that are exactly the same distance apart. We know that that's what we're dealing with. This doesn't help us at all in any of our images, and in fact does degrade the image considerably. Velocity artifact we just have to be aware of, especially when lesions of low density, such as cysts, are encountered, because, again, this is just the phenomenon created by the different speed at which the signal is returned to the transducer. If it's going through something that is liquid, it's going to return faster to the transducer, so the transducer therefore believes it is closer to the transducer than the areas where around the cyst where the signal is slowed in returning to the transducer. So we see the so-called bayonet phenomenon, where often you'll see an artifact within the lesion, such as a cyst, being apparently closer than the signal around it. So this can happen on occasion. Doesn't help us. It was just important to understand it. Fat is the structure we use actually within the breast to determine the relative density of structures. It's our gold standard, so to speak. And we measure everything relative to fat in terms of it being hypoechoic to fat, isoechoic to fat, or hyperechoic to fat. If it has no signal, of course, we call it anechoic. Anechoic to fat, or anechoic period, is, of course, related to cysts, where there are no echoes because this is a purely cystic structure. It is the changes in density within structure that produce echoes, and since a cyst or a liquid structure is totally homogeneous, there is no change in the signal within it, so it appears to be relatively anechoic. Hypoechoic structures are typified by this fibroadenoma, where again, relative to the fat around it, it appears to be slightly less dense, and yet there are many echoes within it. So this is the so-called hypoechoic structure. Isoechoic structures are the hardest to see because they literally are the same density as the fat around. The only reason we can appreciate them usually is because of a very thin capsule, which may separate it, or because there may be some change in the density of the tissue posterior to it because of perhaps some absorption as the echoes are produced on the other side. So, but these are the most difficult to pick up, and not only benign things, but malignant tumors on occasion can have the same density as the fat around it, making ultrasound extremely difficult. Hyperechoic lesions, these are almost always benign, but it's still important to be able to identify them, especially if you have a palpable lesion you're trying to explain. This was a rather large lesion, and a woman, it turned out to be a leiomyoma of the breast. Pretty unusual lesion. It turned out to be benign, but you can see how intense the signal was throughout that lesion. Scanning method, it really doesn't matter which method you use as long as you're consistent. You can use the longitudinal transverse method. The important thing is that we be pretty much orthogonal. So when we evaluate lesions, you can use the radial and anti-radial approach. It really doesn't matter. Like I said, as long as you're consistent in the way you mark the films and the way you do it. We always like to do the patient both supine and upright. I still like to use a standoff pad just really to identify where the lump the patient is feeling is. It's a way to document it on the film because against the standoff pad, the lesion usually will push the tissue up and allow you to identify exactly where it is, whereas without the standoff pad, you don't really appreciate that as the transducer flattens the breast surface completely. So we still do it with and without a standoff pad, so just to mark when there's a palpable lump. We do use markers a lot, especially to correlate with the mammogram. I usually like to put the marker on with the patient upright, where the lesion is, and then so that it'll correlate as closely as possible with the mammogram. This is clearly very important when you've got a very busy breast pattern on mammography or multiple lesions. So we do use that a lot as well as part of our routine scanning method. Next. Scanning technique. Again, just consistency is really the byword here. As I mentioned, most people do it supine with no standoff pad. Like I said, for palpable lesions, we like to scan also with the standoff pad. And you can see here the very subtle palpable lesion, but with the standoff pad, I know exactly where this is, and I know it fits exactly with this hypoechoic mass that we demonstrate right here, because I get a slight rise in the skin that I can appreciate only with the standoff pad. So that's the reason I do it. Obviously, the detail is not quite as good very often because I may be out of the plane of focus of the lesion. So It's not as good for diagnostic purposes per se. What I like to use it for is really just to demonstrate for all to see that that is exactly where the lump is. And for mammographic ultrasonographic correlation, like I said, I do like to scan upright and mark the lesion with a BB, and then often repeat the mammogram so that I can identify that the lesion I saw on ultrasound is indeed the same that I saw on mammography. Next. Normal breast anatomy, pretty straightforward most of the time. Skin, hard to appreciate. There are usually two layers that are separated by maybe 0.2 of a centimeter, or 0.3 at the most. Hard to appreciate without a standoff pad, but you usually can to some extent. Then the subcutaneous fat, as we know, is the relatively low density of material right here. There's always a deep fat layer to the glandular tissue. The ligaments are easy to see, generally speaking. You may or may not see the ducts, depending on their size. As the resolution gets better and better, we're seeing smaller and smaller ducts, so you can't really see them in this particular slice. Glandular tissue, of course, usually stands out nicely as being relatively increased density to fat, and the pectoralis muscle, usually easy to identify as well because of its striated nature. Next. Why are we doing ultrasound in the first place? Well, there are many reasons, and Bob went over most of these with you yesterday. That for non-palpable abnormalities that we use directed ultrasound for, certainly a mass that we see on mammography, a focal asymmetry on mammography, developing density on mammography, architectural distortion, and occasionally just for focal pain. The patient doesn't really have a focal mass, but for focal pain, we will often evaluate these as part of our study with a directed breast ultrasound. The patient who presents with a palpable lump, why would we use ultrasound first? Well, clearly for a young patient below the age of 30. This is our procedure of choice initially. Pregnant patient for the same reason, because of radiation concerns. If a patient who has a palpable lump but has a normal mammogram, we always include ultrasound unless it's a totally fatty replaced breast. Even then, we might still do it if the lesion is very deep along the chest wall and where we feel that the mammogram may have missed it. And a dense breast pattern on mammography in a patient with a lump. These are all, I think, valid indications for getting ultrasound involved, and we certainly use it in that way. Next. Other indications, we already talked about the main one, the old-timey indication, and still one of our major ones, is the differentiating cysts from solid. Still probably the most important. We've talked about these non-palpable and palpable abnormalities that we evaluate. We can use it also to characterize and follow abscesses. It has some role in the evaluation of implants, although it's certainly nothing like the kind of information we get on MRI, but a lot cheaper and a lot quicker. Should we be using it to evaluate high-grade DCIS? I feel we should, and we've already seen some evidence of that from Dr. Newstead and others. We can see the calcifications. We can see evidence of invasion around DCIS, especially in very, very dense breast patterns. Should it be used as an adjunctive screening procedure? Bob Schmidt already has talked to you considerably about that, and I think it does have a role, but it's a very limited role at this point in time. And certainly we use it as guidance for all kinds of interventions, which I'll talk about in the next talk. Next. Number one use still is really to differentiate cyst from solid. Cyst diagnosis extremely accurate, close to 100%, if we use strict criteria of smooth walls, sharp anterior and posterior borders, no internal echoes. You may get some peripheral fill-in when you turn the gain up, and in fact, you do get real echoes lots of times that we're now able to appreciate more and more as the sensitivity and the resolution of our machines increase. We can see debris, hemorrhage, infection, even cholesterol crystals on occasion. And sometimes we are forced to aspirate these if these other echoes become too intense. But we can tolerate some of that, knowing the increased sensitivity and resolution of our equipment. But again, we try to maintain that there should be very few internal echoes if we're really going to call this a simple or non-intelligent cyst. Posterior acoustic enhancement really has to be part of this diagnosis. If it's right on the chest wall, you may have difficulty demonstrating this. There are some tricks you can use to get it off the chest wall to see if there really is posterior enhancement if you're really not sure. And often it is compressible, and you can use that to your advantage as well to make the diagnosis. Next. If you just take the transducer and push really hard, often the cyst will compress. And if this is the case, it is almost invariably going to be a cyst as opposed to a solid mass. Occasionally, you can see debris that will move. So often, I will tell the technologist to be sure you bounce the transducer up and down on the lesion, and these should swirl inside. It's a nice trick if you can get the debris to move, because then you know it has to be a cyst. Next. And again, some of these other phenomena, you can appreciate fat, fluid, and debris levels when you turn the patient. If you sit the patient up, again, it'll layer out on occasion in this projection. So again, you can use positional changes to your advantage to establish that this debris is really real and is creating what we see on the ultrasound as a cyst. Next. And here's a couple of examples. Nice fluid level. This was an interesting case. The lady came in because she had a painful palpable lump, never had a mammogram. She's about 65 years old, and in the right breast. And we saw this fluid level. It was pretty neat because it was so painful that we did go ahead and drain it. And I was getting clear fluid. All of a sudden, I got blood. So we clearly were getting 2 layers of the more serous fluid, and then all of a sudden we hit the layer of where the acute bleeding had accumulated the blood at the bottom. It was pretty dramatic. The other really interesting thing is we found a 0.7 centimeter cancer in the other breast, just as a coincidence. This is an incidental finding for coming in for this mammogram. So the cyst probably saved her life. So cysts are good on occasion. Atypical cysts, we see these all the time, and we know how difficult these can make our lives. We see little ditzels and dotzels, as Bob likes to call these, within the cysts. And as the transducers get better and better, the equipment gets better and better, we're seeing more and more of these findings, and it becomes sometimes a little more problematic in our being able to distinguish what is really a cyst and what isn't. And often we do have to aspirate these. Next. I was talking about cysts that are on the chest wall. This is an old slide, but I think it demonstrates rather nicely what you can do when you have this phenomenon. And this happens a lot. We see these small cysts, and they're right on the chest wall. We can't really appreciate much in the way of posterior enhancement. So the trick is to get it off the chest wall so we don't have to see all of this, what would be normally nice enhancement being absorbed by the pectoralis muscle. So sometimes just sitting the patient up will throw the cyst off the chest wall, or changing the angle of the patient or the angle of the transducer. You have it roll from side to side, or change the angle of the transducer until you can get a little bit of fatty or glandular tissue behind the cyst, and then you'll see the nice enhancement. So it's a nice little trick if you're not sure if something is a cyst or not along the chest wall. Some cysts actually are quite interesting in that they seem to occur in certain regions of the country. This one, of course, occurs a lot in central Florida. That seemed a great deal in that area. And we have one that we see a lot in New Mexico. It's called the New Mexico buffalo cyst, and it's very common in our part of the country. So sometimes you can tell just by the shape of the lesion that it is not only a cyst, but you can tell where this cyst actually originated. Next. Intracystic masses, you do have to be a little careful because you always have to image all the way across the lesion. If you were to image, for instance, right here, you might miss this small little intracystic papilloma. So these imaging has to be, again, done very carefully in order to assure that you really are dealing with a truly benign cyst. Next. And this cyst is an interesting cyst in that it isn't really a cyst at all. It's filled with fat, and this is, of course, a little oil cyst, which was post-traumatic. And it was interesting, this lady, we started the study with the ultrasound because she was only about 25. She'd been in an auto accident a couple of months before and had developed this lump. She really hadn't associated with the auto accident per se. She did notice that she had this lump, and there really wasn't much in the way of through transmission, so we went and did a single mammographic image with the BB on the lump, and now, of course, you can see this was indeed an oil cyst. And again, often they can be entirely anechoic, but the hooker is there's none of the good enhancement we should see behind the cyst. Next. Solid lesions. They, again, have typical features, as you know. For example, with a fibroadenoma, they're usually oval and usually wide or wider than tall. They can be macrolobulated, but more often are completely smooth and well circumscribed in their margins. They are generally isoechoic or more often hypoechoic to fat, so that usually helps us in making the distinction between solid and cystic. Certainly that is our sine qua non. Next. Fat lobules occasionally can look truly solid because, again, if they have a well-defined capsule, it's pretty difficult to distinguish this from the carcinoma or the fibroadenoma that I showed you earlier that looked virtually identical. So the clue is if you can compress it, and usually on one view or another, it will blend in totally with the fat around it and lose that so-called little capsule. But sometimes not. Sometimes it'll be completely encased within glandular tissue and making it impossible to distinguish, and often results in a biopsy. But usually with very careful examination, we can get it to blend in with the other fat, and at that point establish that it is indeed just a fat lobule. It's interesting to me always that fat appears to be low density when it appears in other areas of the breast, and how high density it looks in the center of lymph nodes. And again, I still don't quite understand that phenomenon, but it certainly is very real and one that we put to use every day when we look at lymph nodes. And lymph nodes, as you know, can appear anywhere throughout the breast, usually in the upper outer quadrant, but certainly anywhere. And with that nice little fatty hilum always helps us to identify it as such. And as Bob mentioned yesterday, you can certainly put color flow on these, and if you see a lot of vascularity within the hilum, it certainly helps you as well. Next. There are some features that are, quote, typical of invasive cancer. Usually they do have irregular margins with or without spiculation. They are usually hypoechoic to fat. They usually have posterior acoustical shadowing, although especially if there is a lot of desmoplastic fibrosis around it, which would mean that a lesion which does not elicit a lot of desmoplasia, such as a very, very fast-growing high-grade cancer, may have no reaction around it whatsoever, and in fact can enhance on occasion rather than shadow. So this is certainly not always to be believed. Usually they're round or taller than wide. And again, this is our classic distinction between, quote, malignant and, quote, benign, taller than wide versus wider than tall in general. Not always the case, though. Next. The orientation of the lesion, again, typical fibroadenoma, wider than tall. Typical carcinoma, round or taller than wide. Carcinoma does usually produce lots of irregular margins, hypoechoic appearance, angulation, and shadowing. With all these features, it's hard to call this anything else, and really does demand some kind of tissue diagnosis without the appropriate history to say otherwise. Next. Another case, lesion here, and again, this taller than wide appearance. Pretty typical. Again, very little in the way of posterior shadowing here. This was a very high-grade tumor with very little desmoplasia around it. Next. Here's another lesion, quite angular in its appearance, and again, quite angular on the ultrasound as well. Here, a lot of desmoplasia around it, so we're getting a lot of shadowing. I used to try to guess the grade of the tumor based on how much shadowing there was, and I would always say, oh, this is a low grade, and the ones without shadowing were high grade, and it works in general, but certainly there are exceptions even within that domain. Next. More examples of the kinds of appearances of malignancy. This is not malignancy at all, of course, radial scar, but is virtually indistinguishable at times. And as I showed you yesterday, tubular carcinoma can look exactly like this, and often there's DCIS as well. So when we get this kind of angular appearance to lesions, and if they correspond especially with this appearance on mammography, still requires biopsy. Invasive lobular carcinoma, you saw a lot of examples of that from Dulcie Wolverton yesterday. And again, this classic kind of incredible amount of shadowing, considering the relatively subtle features on mammography, is its striking appearance, and the one that we use to our advantage all the time. Anytime you think about invasive lobular, we should be using ultrasound to help us. Next. Here's a typical example, sort of an asymmetric area of glandular tissue. Here may be a little bit of architectural distortion, but dramatic shadowing all through this area on the ultrasound to help us with this diagnosis. Next. Solid masses certainly are not always typical. Many carcinomas are circumscribed. Some fibroadenomas are irregular, and some benign and malignant lesions we can't see at all on ultrasound. So we have some problems. This turned out to be a colloid carcinoma, and you can see, look at this kind of drizzle effect like that's also described off implants or off silicone that we see where it's interesting. I've seen this several times now with colloid carcinoma, but again, totally atypical of what we might expect. There is a subset that Stavros has identified of solid masses with extremely high probability of being benign, but again, this is a relatively small group with intense homogeneous hyperechogenicity and a thin echogenic pseudocapsule around an ellipsoid mass with less than 4 genital loculations. In this group, clearly these are always going to be benign, but there certainly are no hard and fast rules, just some very good generalizations we can make about masses, but there are always going to be exceptions. Next. Here's some examples. This is a rather large, very dense, smoothly marginated mass that was read as one of my partners as being a cyst with debris in it. And sure enough, on this view, that's kind of what it looks like. There's fairly good through transmission, although not quite as good as you might expect in a lesion this large. Looked totally anechoic here with what he thought was debris down here. Of course, he was completely bamboozled by the technologist who had turned the gain way down. And in fact, this was completely solid and turned out to be a large medullary cancer. So you have to be really careful with the technique, especially when these lesions look relatively well circumscribed like this one. Next. Look at this one. Pretty smooth, wider than tall, a few echoes within it, pretty good through transmission. And look at this one, relatively isoechoic, maybe even a little area within the lesion almost looks like a little fat within it. Well, these are both invasive ductal carcinoma. I mean, how do you know that? Well, because we had to do a biopsy because these lesions were new. But boy, if these hadn't been new, I probably would have followed them. Next. Here's another lesion, pretty smooth on the mammogram. Here, there are a fair number of these fairly gentle loculations. Doesn't look terrible. Again, invasive ductal carcinoma. Next. Here's a series of lesions. They're solid, each one of these. They're irregular. They have mixed texture. They have distal acoustic shadowing. They look pretty nasty. And look at these lesions over here. They're each solid. They're oval. They have uniform texture. They have distal acoustic enhancement, all 3 of these. So which ones are benign and which ones are malignant? These are all benign. These are all malignant. Go figure. So there are exceptions. So like any rule, there are exceptions to it. We can certainly stand behind the fact that when we see lesions like these, we should be biopsying. When we see lesions like these, we should still be following, not necessarily biopsying every single one unless they violate the rules I talked about yesterday. That is, they're new or they're growing. in which case they would all get biopsied. But nonetheless, it's important to remember that there are always exceptions. Next. Some of the other indications following abscesses. This is ultrasound provides a nice way to do that. And you can see this one where it's going right behind the nipple, heading down this way. And as the abscess continued to clear, we were able to demonstrate that it did completely resolve. And ultrasound is really the best way to do that. Next. Implant evaluation, I talked about this a little bit just now, and you can see how, again, we have this sort of drizzle effect when we have free silicone within the the part of the breast that's immediately around the implant where there has been a rupture or a leak. Sometimes it's quite dramatic, sometimes it's very subtle, sometimes it isn't there at all. But when you see this, it is virtually pathognomonic of a silicone leak. Next. Here's an example. You can see this rather dramatic kind of what I call a drizzle effect or shower effect that you're getting behind this little area of silicone leak along the implant. Occasionally, within the implant itself, you can demonstrate a rupture of the envelope, even though the silicone is still contained within the fibrous capsule, of the so-called stepladder effect, which is kind of the equivalent of the linguini sign that we see on MRI. Don't see this as often, but you can on occasion. Next. The evaluation of high-grade DCIS, a bit more controversial, but I think that ultrasound, especially as it has continued to evolve, is really playing a very important role here and should be used on a regular basis whenever we see especially high-grade DCIS, when we get our typical casting kinds of calcifications, especially in very, very dense breasts. We really don't know much about the tissue around here that we can't, because we can't distinguish it from normal tissue. So we routinely do ultrasound on these. Next. And here again, another image of those calcifications. And here on ultrasound, just like Gillian Newstead showed you yesterday, often you can identify these little speculated lesions within the breast that do demonstrate the calcifications and correspond to them. And how do I know that? Well, we actually used ultrasound to do our core biopsy. Patient came in, she was hysterical, she was going out of town, she really wanted to know what was going on, and we didn't have an opportunity on our schedule to do stereotaxis, so we just took her in with ultrasound. We identified these and did a core biopsy and made the diagnosis. So it's surprising how often you can appreciate these calcifications. And here it looks like there is a hypoechoic area around, and it turned out that this was all desmoplasia. There was no evidence of invasion. Next. Here's another case, a little trickier. Patient had an implant, and right along the implant was this cluster of new indeterminate kind of calcifications. They actually had a kind of many of these had the bullet little-like shapes, which told me that this was probably high grade, and also a vague soft tissue mass, or increased density, I should say, around them compared to the surrounding fatty tissue. So we looked with ultrasound. Next. And lo and behold, saw a dramatic shadowing right along the implant. Well, actually, this is the fibrous capsule. Here's the implant down there. So we had a little bit of leeway. So again, the beauty of ultrasound guidance is that we can put needles in with impunity and not really, we can get pretty close to that capsule and really feel very comfortable we're not going to rupture the implant. And yet we were able to make the diagnosis of high-grade DCIS. And there, again, was no evidence of invasion, but everything we see had to be related to desmoplasia around the tumor. Next. And here actually are some of the images from the cores we got. And you can see this here's the central necrosis, rather dramatically with some artifact created by the slicing technique as it went through the calcification. This is all, as you can see, necrotic tumor cells in the center of this area of high-grade DCIS. Next. Lastly, I just want to emphasize again that I think there is a role for ultrasound in screening, certainly for high-risk patients. And we've had a few instances in our practice where we've actually seen this put to use to good advantage. This was a patient who came in for a screening mammogram in May of '99 and presented like this. Rather innocuous looking pattern, nothing exciting. Next. This was the medial lateral oblique view that was done at the time, and in retrospect, there probably is a little bit more density up here than you'd like to see, but it was ignored. It was right along the edge of the film, and as often happens when we get lesions right along the edge, they can be ignored. But the patient insisted that she have an ultrasound. So she was not to be denied, and finally we did agree to do an ultrasound, and lo and behold, at the 9 o'clock position, 8 centimeters from the nipple on the right, we find this hypoechoic, taller than wide lesion with posterior enhancement. Went back and did a directed mammogram. I guess not really supposed to be that way around, but that's what we had to do. And on the next slide, you can see that here was this little tiny cancer way up along the pectoralis muscle. It's still very hard to see, even knowing where it was. This is a 90-degree view, but a little easier to see with good cone compression of the CC projection. So, does ultrasound have a role in screening? Well, clearly there are lesions that will be missed for one reason or another on mammography that ultrasound can help us with. Next. So, ultrasound, very operator-dependent exam, as we discussed. Still an adjunctive study by and large, although cases like the one I just showed you certainly have to think about certain patients in which ultrasound might have a role in screening, which Bob went over yesterday. It does offer an opportunity for enhanced specificity. It provides terrific anatomic correlation if we use it in that way, and it can provide an opportunity for interventional guidance, which I'll talk about in a little bit. And we should see it also as an opportunity for an enhanced physical examination, putting those fingers to use, because we can really make this a truly enhanced physical examination part of our study if we continue to use ultrasound as we should in this way as well. Thank you very much. I'll see you in a little bit.
Many of you know that BI-RADS, which has been out for a long time, has recently been revised and republished. So the 4th edition for mammography is in a volume that also includes ultrasound and MRI. And for the next half hour or so, I'd like to summarize for you what the ultrasound portion of this volume contains. So we'll discuss the indications for breast ultrasound technique and clinical and mammographic correlation, and look at some examples of the categories and the descriptors within them that we use to analyze breast lesions. One of the most important things that I'll emphasize now at the beginning and also at the end is that we need multiple features in our categorizations. Don't just rely on one. If we look at the accepted indications and applications for ultrasound, and as I've heard Dr. Cardonosa speak and Dr. Eklund, through the years these applications have broadened, and we're finding many more uses for ultrasound in breast imaging and management of breast disease than we did before. Always we've used ultrasound to evaluate masses, the palpable masses, and those seen mammographically. Guidance of interventional procedures is really best done with ultrasound. It's easiest for the patient and easiest for us. And among the procedures that we can do are cyst aspirations and fine needle, core biopsy, pre-surgical localization, sentinel node injections, ductography, and even balloon catheter placement for partial breast irradiation. Additionally, we evaluate problems with implants using ultrasound, radiation therapy planning. We can look very well at the lumpectomy sites, the depth, the distance from the skin, and a variety of other features that will characterize those sites well, and possibly in some instances to look for recurrence. It's the initial but not the only, and frequently, imaging technique for young patients, those under 30, pregnant and lactating women. And now I think we see more and more, as we do more and more MRI, we look to ultrasound for the biopsy guidance and correlation. Newer applications, mammographically detected calcifications. If we find a mass, it suggests invasive disease, as Dr. Eklund mentioned, although DCIS can also present as a mass. So if calcifications are found in an area of density, go to ultrasound and have a look. Bilateral survey breast ultrasound in women with known or probable cancers for detection of unsuspected foci. In other words, screening breast ultrasound, and the large multi-center study that's headed up by Wendy Berg, and I'm the co-investigator for that, will start later on this month. Another use, and I think more and more, I'm sure this is in your experience as well, we're using ultrasound to look along with MRI at extent of disease. And here, ultrasound can compete with or it can complement MRI. The equipment is very important, and through the years we've seen huge strides. You need a high-resolution linear transducer, 13 to 8 megahertz or 12 to 5, with a center frequency that's higher than 7 or 7.5 megahertz. That should be your benchmark. The footprint, the size of the transducer itself has grown. In Europe, for a long time, 50-millimeter probes were used because they do screen with ultrasound there. Our footprints were 38 millimeters, and now they're increasing. I'm sure if you look at some of the equipment out in the exhibitor area, you'll see that as well. If you're considering purchase, you want to try the feel of these probes in your own hand and to know that you're going to be scanning, but also to do interventional procedures, so they should be comfortable. Use the highest frequency. That won't compromise penetration, and only rarely will you need a lower frequency probe than the frequencies I mentioned. The field of view should be appropriate. You don't want it too big, so that too deep, so that the lower portion of the image contains no information, nor too shallow, because there you'll have a lot of speckle artifact, and it will be very difficult to characterize the margins of masses or even to see them. Feature analysis is what we're going to talk about, and what I'll present to you are the categories of features that the BI-RADS contains. And again, multiple features are the best predictors. Don't just select one. At the boards, for example, I know that probably we have a good proportion of residents here who are anticipating an enjoyable day in Louisville. But don't just jump on taller than wide or wider than tall. In showing cases, breast cases, we hear that as the first thing. Oh, it's wider than tall. It has to be benign. Wider than tall is not always benign. In fact, often cancers have a horizontal orientation. But what the take-home message should be is that fibroadenomas are not taller than wide. So wider than tall, cancers and benign, taller than wide, don't put fibroadenoma in your differential. But the most important features are those of shape and margins, just as they are for every other imaging technique. Starting with the BI-RADS, we included the background exotexture just as you look at density mammographically and report it and as you assess your films. So here you can have homogeneous echotexture composed uniformly of hypoechoic fat or echogenic connective tissue arcs, the Cooper's ligaments, or echogenic fibroglandular tissue and a thin layer of subcutaneous fat. Also, there's heterogeneous echotexture, and it has a mammographic correlate. So they're focally or diffusely variable in echotexture with lots of small areas of increased and decreased echogenicity. And one of the questions we asked as we wrote the protocol for the Akron study is, does this type of tissue lower the sensitivity of ultrasound just as very dense tissue lowers the sensitivity in mammography? Here's an example for you, and you can see that normal skin is up top, and the fat lobules with their connective tissue encapsulations. And there's an area here of heterogeneous echo texture sitting just above the pectoral muscle, which you can see easily here. Now, what does that mean? Is it abnormal, normal? It's probably normal, but in this instance, the mammographic appearance clarifies the issue for you. A hamartoma is present here, and the encapsulation is easy to see mammographically. A mass occupies space, and it should be seen in two projections. And wherever we could, we took from BI-RADS from mammography definitions and descriptors that would also apply to ultrasound. Masses can be distinguished from normal anatomic structures, and in ultrasound, it's ribs or fat lobules that frequently pose problems. And the way to resolve these issues are with two or more projections and real-time scanning. An oval area, hypoechoic, with respect to the echogenic fibroglandular tissue around, isoechoic with fat lobules. And is this a fibroadenoma? It's circumscribed. It certainly doesn't look alarming. The orthogonal view shows you at the same depth. Note that the depth is the same on the two. All you're doing is turning your transducer so that it's the orientation of the transducer that is the only change. And here you can see it elongate, and you have established that this oval area that is hypoechoic is a fat lobule. It's important when you are using ultrasound as much as we do to be able to correlate mammography and ultrasound. And there you have to bring to ultrasound the pattern of fibroglandular tissue and fat that you've seen on the mammogram, and also to account for a change in position from upright to supine or supine oblique. This is a spot compression view of an area of focal asymmetry that was present mammographically, and ultrasound was used to look for an underlying mass, perhaps here, and one wasn't found. But what would you expect the sonogram to look like? Will it be hypoechoic? Will it be echogenic? Does this fit your mental picture of what it should look like? Well, the patient here is upright. Here she's lying down, head here, feet there. And I think you can see this pattern of fibroglandular tissue. It's white on the sonogram as well. And it is enclosing areas of fat, just as you see mammographically. So that correlates well, and it will increase your confidence level in excluding an abnormality. For the first category that we'll look at in terms of characterizing masses is that of shape. And we've tried to make things as simple as possible. During the 5 years or so that the BI-RADS was being written, we went from lumping to splitting and back to lumping, and somewhere in the middle is where we ended up. So we wanted to make it easy and to make it useful. The shape descriptors that we included are oval, and that's defined as elliptical or egg-shaped, and these are the mammographic definitions just imported into the ultrasound lexicon. And it can include 2 or 3 undulations, that gentle lobulation or macrolobulation that characterizes fibroadenomas. So oval is one, round is another, spherical, ball-shaped, circular, or globular, again, directly from the mammographic descriptor. And then, if it's not oval and if it's not round, it can only be irregular. So it's neither oval nor round. It can't be almost oval or almost round. If it's almost oval, it's irregular. Some examples here are 2 views of the same mass, and it was fibrocystic change. There is a circumscribed border, but the mass itself, in terms of shape, is oval. And in ultrasound, we'll talk more about it in a moment, orientation is another feature category that is unique to ultrasound. And as you look at masses, I think instinctively you use the orientational feature to help you in your level of suspicion. There's a little calcification sitting right within this heterogeneous mass. So that was oval and parallel, and should you biopsy it, you will find it concordant with a diagnosis that was rendered of fibrocystic change. A round mass in another round mass, two views, they're orthogonal, and you've already probably characterized other things in addition to the shape. This was an intracystic papillary carcinoma, and its margins are smooth because it's growing in a fluid medium, but round in round. And you'll note that this is a mass that needs to be addressed. An irregular mass looking very much like the mass that Dr. Cardonosa showed you, and this is the same, it has the same histology. This is a poorly differentiated invasive ductal cancer, and it has the enhancement posteriorly, a beguilingly circumscribed border, but it has microlobulation, and you really can't force this into round or oval. It has an irregular shape. Orientation is unique to ultrasound as a feature category, and it's defined with reference to the skin line. And parallel, wider than tall, or horizontal are synonymous in terms of the elongated orientation that is parallel to the skin line. And again, fibroadenomas are generally oriented horizontally, wider than tall, or parallel to the skin line. But many cancers are as well, so it's hard to use that as a unique characterizing feature. Shape and marginal characteristics really do dominate, as they do in MRI, mammography, and in other organ systems as well. Diagrammatically, the orientation feature and shape are shown here. This is an oval and horizontally oriented mass. If you take as an underline for the title of the slide, the skin line. So the anterior-posterior distance is less than the longitudinal or the horizontal distance. And in your differential are fibroadenoma, carcinoma, cyst, sebaceous cyst, and a number of other lesions. And here's an example of a fibroadenoma. It has a macrolobulated, this is oval, and the marginal definition is circumscribed. We'll talk about that in a moment, but the orientation is also parallel to the skin. Here's another parallel mass, very different, and you look at it and you see that it has spicules extending out into the area around it. This is a typical invasive lobular cancer, and frequently they wander through skin in a horizontal fashion, the single file progression of cells, and then they form mass-like areas, as you see here. There are other things that this could be. It could be diabetic mastopathy, a fibrotic reaction that you find in insulin-dependent long diabetics of long standing. But this must be biopsied, and here we have a parallel orientation. And that's a wider than tall mass that is not benign. Now, we have a parallel mass. We've seen both benign and malignant. And now we'll go to not parallel. And here the anterior, posterior, or the vertical dimension is greater than the transverse or horizontal dimension. And the synonyms are vertical or taller than wide. This was written up a long time ago by Bruno Fornage. And it's helpful in conjunction with other features that you use to characterize masses that you are looking at with ultrasound. Round masses are not parallel. They are not parallel within this group. And non-parallel masses can also be obliquely oriented. And here is a diagrammatic representation where the anterior, posterior, and the longitudinal dimensions are the same. What's missing from the differential listing here? Fibroadenoma. We have carcinoma, we have cyst, and we have abscess. Going to the next feature category, its margins, and this along with shape is one of the most important features. It's the edge or border of the lesion, and we only have two possibilities here. It's either circumscribed, as you see here with this simple cyst, well-defined, smooth, distinct rim, and all of the other features there go along with the diagnosis of a cyst. It's anechoic, it's enhancing, it is circumscribed, and in this instance, it's oval. And masses that are not circumscribed, and that's the key thing, can have any or all of these features, and among others: indistinct, angular, microlobulated, and spiculated. Now, the BI-RADS lexicon was a consensus document, and the committee that reviewed it voted on whether or not we should include irregular as a marginal descriptor. And the choice there of the majority was to use irregular only for shape and not to use it across two categories. So you don't find irregular there, but I think when we look at masses, we think of irregular margins too. But here's an example of a mass that is certainly not circumscribed, and its margins are indistinct. And the indistinctness actually signifies the movement of this tumor out into the surrounding tissue. It's eating away at the fat here, and these two views are orthogonal. So we have here a mass that is whose shape is irregular, whose orientation is not parallel, and whose margins are not circumscribed. A very suspicious mass. An example of a mass whose marginal characteristics can be described by angular, where the sharp corners are formed by portions of the mass that make acute angles. But it's also microlobulated, and I think you can see here a few spicules as well. Again, irregular shape, not circumscribed, and not parallel. Microlobulation. If you look at this, would anybody here not biopsy this mass? I don't see any hands, but I think everybody probably would. Would you find that it to be discordant if the histology came back as benign? Not really, right? It was a mixed lesion. It had some fibroadenoma in it, some sclerosing adenosis, and there was a microscopic radial scar within it. But I think it's a good example of microlobulation to contrast with the macrolobulation that we see in fibroadenomas sometimes. Spiculation, we can see this as neatly with ultrasound as we can with mammography. There is a huge echogenic halo around the central portion of this mass. These are orthogonal views, and here's a spicule, sharp spikes projecting out from the central portion of the mass. People often ask whether you measure the halo when you see something like this, and I think what we have come to do is to measure the hypoechoic portion of this mass and also the halo itself. The presence of the halo doesn't mean that the tumor has extended into the area around it. That's the only determination of that can be made microscopically. This was not an invasive ductal carcinoma. This was a primary lymphoma of the breast, and it's an unusual presentation. Looking at the differential listing of irregular or spiculated masses, it includes carcinoma, surgical scar, fat necrosis, radial scars, abscesses, and the granular cell tumor, a benign mimic of carcinoma. Looking at the boundary zone, and this was another problem when we were writing the lexicon, whether to include it or not. Its significance is uncertain, but it is something that we notice. And here we only have two possibilities. None, which means that there's an abrupt border between the lesion and the surrounding tissue, and echogenic halo, where there is no sharp demarcation between the mass and the surrounding tissue, as we saw in that indistinctly marginated mass and in the lymphoma. An example of an abrupt demarcation. These are lobular areas of lobular hyperplasia of pregnancy. They're sometimes called lactating adenomas, where this very hypoechoic mass is seen against the echogenic fibroglandular tissue. But here you can see that there is no halo around it, as there is in these perpendicular views of a small cancer, and the spicules you can see. This halo is present around cancers in probably 30 to 40% of times, and you also see it in around abscesses. The echo pattern isn't as helpful as some of the other feature categories, but it includes anechoic without internal echoes, the simple cyst, and if you are not careful, you can mistake a hypoechoic lesion, a medullary carcinoma, for example, as a cyst if your contrast settings are too high on ultrasound. Ultrasound requires a broad grayscale, and you can achieve that by using a high dynamic range. Hyperechoic equal to the fibroglandular tissue. Hypoechoic we are defining as relative to fat. It has to be relative to something. And a hypoechoic mass, I'll show you an example, would be characteristically either a complicated cyst or a fibroadenoma. One of the big changes in the BI-RADS lexicon is the term complicated cyst, which we're using for a cyst that contains low-level internal echoes throughout, as opposed to a complex cyst where you have an anechoic and an echogenic component. This is a hypoechoic mass. Note that you can't call it, can you call it oval? You might be able to. Its orientation, though, is not horizontal. It's not parallel to the skin. It is a vertically oriented mass, and this was a poorly differentiated invasive ductal cancer. Here's an anechoic cyst, the same one I showed you a few minutes ago. Isoechoic, the same echogenicity as fat. And then we have this collection of complex cystic masses with combined cystic and echogenic zones of transition, and mixed hyper and hypoechoic masses, where the masses are hyperechoic to fat, and portions are hypo or isoechoic to fat without a cystic component. This is a cyst. This is a complicated cyst. It is the view that shows you the cyst as round. In the other view, it was oval, but it's a circumscribed mass, and it contains low-level echoes throughout it. It was aspirated, and its contents were just yellow or greenish fluid. This is a hematoma. After a cyst was aspirated, here's a second cyst and a third cyst, but the cyst, the simple cyst, filled with blood, and we were left with a complex mass, a complex cystic mass, and this is the reason why one should image first and then do a procedure later. Another complex cystic mass, and here you need the history. It could have a number of differential considerations. Note that the echogenic component has floated to the top. This patient was lactating, and this is the fatty component and the watery component of her galactocele. And here you need the history, and the mammography helps you. The patient was in her 70s, and she felt a new mass. She had been in earlier for a mammogram earlier, a few months earlier, and here is the region that she felt. It looks fatty. And on the other view, this is craniocaudal. Here's medial lateral oblique. You don't see a spiculated mass. You might expect one in a new mass in someone in her 70s. And going to ultrasound, as you should. And here I'm only showing you this because with something that is fat-containing the way this is, you might neglect ultrasound. But ultrasound will give you the answer here. She had been in a car accident, and this was a hematoma on its way to becoming fat necrosis. Posterior acoustic features, no change. Enhancement, increased. Shadowing, decreased posterior echoes, and combined pattern, both shadowing and enhancement. This is another galactocele. It has a number of septa within it, but it yielded its fluid, and we were able to evacuate it completely. Shadowing, typical cancer, again, eating away at the surrounding tissue, the fibroglandular tissue, and making its way up into the fat. And you can see this club-shaped protrusion moving up. There are additional things that you can use ultrasound for, and you should always look. The effect on the surrounding tissue is one, just as I've pointed out. And identifiable effects are duct changes, Cooper's ligament changes, edema, which you can see easily with ultrasound, architectural distortion, skin thickening, and retraction. This is edema. The patient had congestive failure. As you can see here, another long list of differential considerations, including radiation, mastitis, inflammatory breast cancer, mastitis of any cause, and this is the typical pattern. It's a pattern of reticulated and connecting areas. It's more angular than a ductal pattern, and those of you who do venous studies for DVT will recognize edema. It looks like edema anywhere else in the body. Anybody recognize this? This patient already had breast cancer, and this is her lumpectomy site. This is mature scarring in 2 views, and if you look in those patients who have had radiation in addition to the surgical excision, you can find a V and follow the area of scarring, actually the path of the scalpel, all the way down to the area of the lumpectomy. You can look on either side for recurrence if you suspect it mammographically or physically. In finishing up here, I just wanted to show you some cases of calcifications present on ultrasound. You should look for those as well. Macrocalcifications are easy to see with shadowing. Microcalcifications out of a mass and in a mass are also present. This is a case of DCIS. You can see architectural distortion in addition to the calcification, some of them with ring down, as they are going through the tissue here in a linear fashion. I have 2 more views of that same case. Here it looks a little bit more spread out, and in this view, some more ring down. But you can see that there are small masses possibly or distended ducts in a confused pattern within the echogenic fibroglandular tissue. This was the corresponding spot compression magnification view of those calcifications. Here in a duct, you can see the distended duct, you can see in the calcifications. As a group here, there's enough substance for them to calcify. Microcalcification doesn't occupy enough of the ultrasound beam to shadow. This patient had metastatic ovarian carcinoma as a mass presenting 10 years after her initial diagnosis was made. 2 views. There was definitely a palpable mass with architectural distortion mammographically, and within this poorly defined mass that you see on the mammogram, the calcifications that you can identify are there, and those were summomatous calcifications. In some special cases, there are distinctive findings, and we included those in the lexicon: microcysts, intraductal masses, masses in or on the skin, foreign bodies, lymph nodes within the breast, and axillary lymph nodes. And we included vascularity without seeing that it could provide much in the way of helping, except as another feature. This is an example of clustered microcysts, and here they are. These basically are distended acini, and these are leave me alone category 2 lesions, but look carefully and make sure that there is no mass. If there's mass, they require biopsy. In intraductal papilloma, those of you who have a panoramic type of display on your ultrasound systems can follow the duct all the way from the nipple back out and see within it the distension of the duct by the masses. Silicone, you recognize, that is lying free outside of the implant, and vascularity adjacent to a lesion. The lesion's morphology tells you it's malignant. Surrounding, and this was DCIS with some vascularity around it that was more than the surrounding tissue, and here a large cancer with a lot of vascularity that is delineated by power. Again, the lymph node easily recognized, but if you're using ultrasound to characterize a mass that you can't see the fatty hilus of on mammography, make sure, as I mentioned earlier, that you correlate the pattern of tissues. This nodule is the same size as what you see mammographically. It's lying within fat, and it has glandular tissue around it, as you see here, and you have to account, as you would, for the patient's change in position. So in conclusion, you want to make a conclusion. You may have an incomplete study with mammography, with ultrasound, and require mammography, MRI, and previous exams to make your final assessments. And these are the familiar final assessments with the addition of final assessment number 6, a known carcinoma example would be a patient coming to you for a consultation. In mammography, a probably benign lesion 3 has a less than 2% likelihood of malignancy by Ed Sickles' work. Can that transfer itself to ultrasound? We're not certain, and it's one of the goals of the Akron study. You can write a combined assessment consisting of mammography, ultrasound, whatever, and MRI if you're using it, knowing that there is no MQSA requirement for anything related to ultrasound or MRI. It only deals with X-ray mammography. The most suspicious assessment dominates in the management recommendation, and we will look at category 3. And for the residents, if you're asked to analyze a case, do this. Check the technical quality before you attempt to interpret it. Appreciate the importance of real-time observations. You can ask about them. And in analyzing a case, use feature analysis and the categories first. And most important are shape, margins, and orientation, and use them all. Descriptors within each of the categories can help you, and integrate ultrasound with other modalities and clinical data, and in the end, reach a conclusion and suggest a management plan. Thank you very much.
We've been studying breast MR now for a good 15 years, so it's certainly just beginning to move into active clinical practice, and I'm really happy to see that, because I think all of us who do breast imaging will learn how to use breast MR and must use breast MR in the future. And I hope to show you in this introductory lecture, we're going to hear a lot more about MR this weekend, just review the highlights of where I think breast MR fits into our workup. You've heard some very nice talks this afternoon about mammography and ultrasound, and this is really a very exciting, relatively new piece, a new whole vocabulary, if you will, that we need to learn, a new whole way of imaging that's going to really enhance our breast imaging practices in the future. Up until now, there's been relatively poor integration of MR into the most breast centers because of the problems that have to do largely with no standardized technique for breast MR. The people who do MR for the most part are not breast imagers, therefore don't have the background breast imaging, limited availability of magnet time, and all of these other issues. I think when it comes to magnet time, I've gotten quite bold. I really think that if you go down and look and see what kind of cases are being studied on your magnet, you'll see a lot of pain in the neck and various neurological problems, and pain in the back and pain in the knee. And I really do think that a woman with an index diagnosis of breast cancer deserves equal magnet time. So I think batch booking is a very efficient way for breast imagers to have magnet access. So in our practice at University of Chicago, we batch book our cases, unlike at NYU, and we have a whole day when we just do breast MR. It works very nicely. You need a dedicated breast coil, you need a high field strength magnet. These are the recommendations from the International Working Group for Breast MR, which published suggestions and recommendations for practices who are doing breast MR. Slice thickness approximately 2 millimeters. You can use subtraction or fat suppression, as I will show you, to get good images of the enhancing breast tissue. And you have to have the ability of being able to biopsy the lesions, which you see on MR, which you're unable to find, and there will be many of them unable to find with conventional mammography and ultrasound. MR, when you think about it, is an ideal technique for breast imaging because it's non-invasive, there's no ionizing radiation, and most importantly, you have a multiplanar display, so you have tomographic images of the breast, which in a unique way, which we're unable to get with conventional techniques. We know that the inherent tissue contrast depends upon the tissue proton density, proton relaxation rates, T1 and T2, and the fat glandular ratio. Tissue contrast is improved by intravenous contrast, gadolinium chelates, so we need to use gadolinium when we're doing breast MR to evaluate for possible breast cancer. And we need reduction, contrast accumulates in cancers, we have reduction in the T1 relaxation times, T1 weighted pulse sequences are usually used for imaging the breast, and we want to optimize tissue signal differences, and I'm going to show you a few different ways of doing that. And we need to decrease the signal from fat because fat is bright and will obscure malignant lesions. Now, the big bugaboo we've had in the past has been the debate about whether or not we're going to concentrate on high spatial resolution or high temporal resolution. And by temporal resolution, I mean how quickly we image the breast after injection of contrast medium. And because of limitations of the scanners up till now, the breast imagers have had to decide which technique they're going to focus on more. We've always developed at NYU, we developed sort of a hybrid technique where we were looking at the best temporal and spatial resolution compromise we can get. With the new scanners and with parallel imaging, it's going to be very exciting. We should be able to improve both our spatial and temporal resolution in the future as we get coils with more channels and parallel imaging capabilities so we can image both breasts very quickly simultaneously. The images I'm going to show you, though, today have been done because we don't have parallel imaging set up yet, are being done with standard 1.5 Tesla magnet, both a Siemens at NYU and a GE at the University of Chicago. So our protocol is the following. When we do breast MR, we want all of the recent breast imaging studies available to us. So we look at the old mammograms, we look for the indication for the study. We want to know precisely why we're doing the MR, what question do we have to answer. We protocol the examination depending on the history. We have a nurse who's assigned to us who gets the history and consents the patient. It's good to start the IV outside of the room because you want to minimize the magnet time. In our protocol, it's about 25 minutes of patient time within the magnet itself. And then we mark the palpable masses and the nipples with vitamin E tablets and scars, just as we do with conventional mammography. The technologists have to be trained to position the breast in the coil. This is very important because most MR technologists are not trained in breast imaging. It's important for the patient to lie prone and for the breast to be pulled down into the coil and positioned as perfectly as possible with the nipples in profile. And for those patients who we are screening with MR, we want to perform and schedule their MR examination in week 2 or 3 of their menstrual cycle. That is when the parenchymal enhancement is somewhat less. With diagnostic cases or patients suspected with breast cancer, we don't worry about it too much, but if we're screening, we like to optimize it. This is the breast coil we had at NYU. It's a Siemens coil. Patient lying prone, technologist pulls the breast down into the 2 wells, and patient's pretty comfortable most of the time. Now, the other thing about breast MR, in addition, as you just heard from Dr. Mendelsohn about looking at margins and shape of lesions, we're pretty good already with our experience with mammography and ultrasound, knowing what malignant lesions look like in terms of their morphology. We're pretty good at that, and it's very similar from mammography and transiting into ultrasound. With MR, we have a whole new way of looking at lesions, and that is the contrast enhancement. And we have gadolinium. We can look at the temporal resolution and temporal morphology of lesions as well. And gadolinium is a reflection of the tumor angiogenesis, perfusion, and the extracellular space. The dose and rate of delivery is important. You want to give a bolus injection of contrast, followed by a bolus of saline, and then begin imaging immediately. And depending on lesion histology, the temporal resolution and the morphology will be different. 2 important papers, I think, on morphologic criteria on MR, one by Dagani and in Nature Medicine 97, and another one by Linda Nunes from University of Pennsylvania, looking at morphology of lesions only. And as you'll see, they were able to achieve very nice sensitivities and decent specificities by just using morphology on MR. And because we're getting tomographic sections through lesion, of course, we can get exquisite morphology. We don't have to worry about overlapping parenchyma as we do with mammography. And Dr. Kuhl, who is speaking at this meeting, should be speaking with you tomorrow, wrote a landmark paper in Radiology in 1999 when she looked at just at temporal criteria, just at when you image, how does a temporal resolution help you decide whether a lesion is benign or malignant? And these were the results from her paper, just looking at temporal resolution, achieving high sensitivities and specificities. And she published the curves that we all use now when we're doing kinetic studies of how rapidly the lesion takes up contrast from time of injection, 1, 2, 3, 4, 5 minutes, depending how long you image out from your injection, showing that malignant lesions enhance rapidly, and there's some washout. Plateau type curve is described. These lesions, some can be benign and malignant, and slow, steady enhancement is more indicative of benign abnormality. And these are curves, persistent plateau and washout, showing likelihood of malignancy, with a washout type curve being a fairly good predictor of a malignant lesion. This combined with morphology, together we can then come up with even better sensitivities and specificities if we use both of these criteria. I like this paper that was published last year. It's in Active Radiology, looking at dynamic MR, very nice study, looking at 92 women with 109 lesions. And these authors concluded that the time to peak enhancement was the most important dynamic criterion, and that morphologic assessment was also important. And these are the kind of curves we produce in our practice. So this would be a curve, for example, of the parenchyma surrounding a lesion or elsewhere in that breast, and these would be the time of enhancement of the lesion in question. We may do 2 or 3 curves within the lesion showing rapid enhancement, and in this case, some slight washout. This is the technique that we use. I'm not showing you all of the technique, but the most important the sequences that we use for diagnosis that I've found are pre- and post-contrast spore gradient echo T1 sequences. And we have a 58-second acquisition of both breasts, which is a very, very good temporal sequence. And I find that I get most of my information on the first post-contrast sequences, because that's the sequence that allows me to more accurately find the cancers and differentiate them from enhancing parenchyma. We do throw in between the 3 and 4 minute one high-resolution sequence, which takes a little longer. It takes 1 minute 48 seconds, something like that. But all of the others are done in 58 seconds. So we have 1 pre, 2 very rapid post-contrast, a high-resolution sequence between 3 and 4 minutes, and then at 5 minutes, a standard temporal 58-second acquisition. We acquire our data coronally. Now, to do both breasts, you have to do either a coronal or axial acquisition. Until parallel imaging came along. With parallel imaging, you can do a bilateral simultaneous sagittal acquisition. But we use a coronal imaging because we think that we get less interference with cardiac motion and that we can see the axilla a little better than we can with axial acquisitions, but you can use either. And of course, we read all of our images soft copy. If you were to try and print all of them up, you have more than 800 images of the breast, so it would be too cumbersome to do that. So we read all of our images soft copy at the monitor. Here's just an example of the kind of images we're getting. This is a 44-year-old high-risk patient. We're doing some screening, as I'll tell you about later, but you can note that she had a very dense mammographic pattern, difficult to find a small cancer of this type of pattern. And here are the 4 coronal post-contrast sequences. So this would be 1 minute, 2 minute, 4 minutes, and 5 minutes. And you can note that there's rather asymmetric parenchymal uptake, and we see this fairly frequently. But you can see by the final 5-minute post-contrast injection how densely enhancing the normal breast parenchyma is, and how it would be much more difficult to find a small little tiny cancer at, let's say, even 2 minutes than it is at 1 minute. And this is why I think temporal resolution is so important, and this is why we rely a lot on our early post-contrast sequences. Here we can just show you if I can get the pointer to work here, a coronal acquisition. Here we go. And we come through both the breast sides. This is the same patient, just showing the asymmetric parenchyma, and here you'll see the enhancement right and left. And this is how we read. We just scroll through the breasts in that fashion. And you can also rotate around and look at them in any sort of oblique way that you want. And here's another patient, so we're pretending we're sitting there at the monitor reading the patients. We differentiate and follow the blood vessels so we can differentiate the arteries from small lesions by seeing if we can follow them on the various sequences. So this is how we read our routine examinations at the view box. And then we can print up the multiplanar reconstruction. We can print up axial, sagittal, and coronal sections of the normal breast or any area of the breast we consider abnormal. And we usually print up a few hard copy selected sequences for the referring physicians for easy reference. Now, I just want to run through you, having gone through just very quickly technique, you'll hear a lot more detail about that tomorrow. The interpretation, and just as you heard from Dr. Mendelsohn very nicely about the ultrasound lexicon, we have a lexicon for MRI, and I'm going to use that terminology here for you. We look at carcinoma. Let's just look at some basic lesions. We can look at carcinoma, fibroadenoma, sclerotic fibroadenoma, papilloma, and lymph node. We look at their intensity on T2 weighted images, and we can look whether they have rapid or intermediate enhancement, and look also and evaluate the kinetic information, whether there's washout present or whether the enhancement is persistent. So we can see that there's persistent enhancement in many fibroadenoma, although in young patients we may have very rapid enhancement and overlap with malignancies. In lymph nodes also we can see very rapid enhancement and washout. So there, again, in those lesions, we have to put the morphology together with the kinetic pattern. Here's an example of a rim-enhancing carcinoma, ring enhancement being a fairly reliable sign of malignancy. Here are our non-subtracted images. So this is our coronal acquisition pre-contrast, showing an irregular, obviously malignant-looking mass. Here we see the heterogeneous, but mostly rim enhancement, and here is our maximum intensity projection image showing the lesion very nicely. Then we can subtract. We do subtraction on all our cases. So here we have another patient with a large tumor, irregular margins. Here's the coronal pre-contrast and post-contrast image. And here's our kinetic data in this case. This is the surrounding breast tissue. This is the enhancement characteristics of that lesion I just showed you, very rapid enhancement and washout here. And these are the kind of maximum intensity projection images of any obliquity we want, showing a primary carcinoma and a little secondary lesion here. Now, you heard from Dr. Mendelsohn, ultrasound-MR correlation is becoming an increasing use of ultrasound because we're finding a lot of lesions with MR that were not detected necessarily before the MR examination with ultrasound. And the problems we have with this are that ultrasound, the patient is supine. In mammography, the patient is upright. In MR, the patient's prone. So it couldn't be a worse combination. And sometimes, particularly in larger patients, it's very difficult to correlate the two. So I think it's important when you're trying to relate a lesion that you see on MR to a lesion that you see on ultrasound to be sure that the size of the lesion and the morphology of the lesion are identical on the two modalities. Otherwise, it is necessary to do an MR-guided biopsy to be sure that you're biopsying the lesion of concern on MR. And in the study by Dr. La Trenta in Radiology in 2003, they found a sonographic correlate for the MR visible lesions in about 23% of the time. The remainder of the time, MR biopsy was needed. We have very high sensitivity on MR for carcinoma, particularly invasive carcinoma. The false positives are the ones I mentioned already, fibroadenoma and some lymph nodes, but also papilloma, fat necrosis can give you a very, very rapid uptake of gadolinium. Morphology may help you here and often does. Fibrocystic change, sclerosing adenosis can all give you false positives. But again, the temporal resolution and morphology are important to help distinguish in many cases. In the lexicon, the margins, we describe the margins of masses. And again, here's some example of smooth and lobulated. This is in the MR lexicon. These are fibroadenomata here, so we have a smoothly outlined mass. You see a couple of them here. Sometimes in fibroadenomata we see unenhancing internal septations, which are pretty characteristic of fibroadenoma. When you see them, increases the confidence of a benign diagnosis, as opposed to the irregular spiculate margins that we see with carcinomas. So here we have 3 carcinomas showing irregular spiculated. Note the very brisk enhancement we see here. Here's another spiculate mass with another one behind it. So this is the kind of, there's a lot of overlap with what we already know about morphology. And the shape, round, oval, or not specified. Some round. And then we look at the enhancement characteristics, whether the enhancement of the lesion is homogeneous or heterogeneous, whether there's rim enhancement, which would indicate it's probably a carcinoma or less like an abscess perhaps, dark internal septation, probably a fibroadenoma, enhancing internal septation and central enhancement, you worry about carcinoma. So these are the descriptors that we see in the lexicon. And here is just some example of different types of lesion enhancement, rim enhancement here, sort of heterogeneous here, internal unenhancing septations here in this fibroadenoma, and heterogeneous enhancement in this carcinoma. So those are the main descriptors, the morphology of the lesion and the type of enhancement. Another examples of more lesion enhancement. Here we see smoothly outlined heterogeneous enhancement. Here we have, again, rim enhancement in this carcinoma. Here we have heterogeneous enhancement in these 2 lesions. Now, when we are developing at the University of Chicago as a workstation, our own workstation for looking at lesions and getting good kinetic data more easily than we can with the device, the ROI, putting the marker on the lesion itself and producing the curves with the func tool that we have on the GE. Each of the machines has a slightly different version. But here you can put the ROI in the center of the lesion, and then we can move it around. We can actually draw the ROI, which gives us sort of nice curves. And here we can display the first post-contrast sequences in one particular slice with all the subsequent ones and eyeball the degree of enhancement, which makes our reading of the lesions easier. Here's a patient with multiple little nodules in the periphery of the breast. We're thinking about peripheral papilloma. Here's a spot magnified view. Here's an ultrasound of one of these nodules, showing a fairly sharply outlined nodule. Here's the MR, coronal slices showing multiple enhancement of these small nodules, which were multiple peripheral papillomata. These are non-subtracted images here. Here's a patient with a bloody nipple discharge and a palpable mass. Here's the mammogram showing irregular mass. Here's the ductogram showing the somewhat dilated ductal system up to this irregular enhancing carcinoma. And here's the MR showing the irregular heterogeneously enhancing mass with tumor down into the irregular enlarged and pathologic lymph node. Here's the curve of the index tumor here. All right, I'd just like to say a few words about ductal carcinoma in situ. A lot of the early literature, and even some of the current literature, states that MR is not very useful for DCIS. In fact, I think that's not true. The enhancement pattern is somewhat different than that of invasive cancers, as is the morphology. And these are the terms that we listed in the lexicon to look for non-mass enhancement. So these are lesions that are not forming a mass, but we're seeing enhancement which can be linear or diffuse, and if it's linear ductal, we can describe it as smooth, irregular, or clumped. It can be segmental, regional, or in multiple different regions. This is an example of a patient with DCIS with segmental non-mass enhancement. These are the terms listed here, whether it's septal, dendritic, stippled, punctate. You don't have to worry too much, but it's important to be able to recognize that when we see linear non-mass enhancement, as is in the case here, this is actually enhancement of the ducts within a breast lobe in a patient with DCIS, that this is probably a significant finding and could well represent ductal carcinoma in situ. Here are some more examples of non-mass enhancement due to ductal carcinoma in situ. Here on the coronal image, remember, we're cutting sort of across the ducts, but here we have linear enhancement, and here we have sort of clumped enhancement as these ducts are filled with enhancing tumor, and we're sort of cutting across them. This is just a summary of the literature about ductal carcinoma in situ. There's not a lot of studies. Many of them have small numbers. The study by Dr. Gilles that was published in Radiology in 1995 had 36 cases. 34 of the 36 cases of ductal carcinoma in situ were 24 of the 36 were high nuclear grade, and all but 2 of them showed rapid initial enhancement. And the shape of the enhancement is defined here, 12 linear, 10 ill-defined, 4 nodular. The other studies are somewhat smaller. Some of these studies did not have good kinetic data, so looking at the rate of enhancement was not possible, but the segmental nonlinear enhancement is pretty much typical for DCIS. So here on this slide you have examples of clumpy DCIS enhancement, nodular enhancement, segmental enhancement, and 2 areas of more linear enhancement. Here's a patient from our own practice who had a carcinoma on the opposite breast, had been treated several years ago. Here are her mammogram views, CC views, and ML view. And this is a patient with the linear enhancement. We went back and tried to find something on the mammogram because I couldn't believe that a patient could have DCIS that was this extensive without some mammographic finding in a patient who did not have a dense breast. She had a relatively fatty breast. Couldn't find it. We did spot compression views, as I'm showing you here. We did magnification. There are no calcifications. There's no mass, and yet the MR shows diffuse enhancement. And here are our multiplanar reconstruction showing the DCIS in the sagittal, axial, and coronal plane. And we did an MR-guided loc on her, and she had almost a quadrantectomy for intermediate and low-grade ductal carcinoma in situ that is mammographically occult. And it's because of cases like this that I think that we shouldn't confine ourselves to doing MR only on patients with dense breasts when we're looking for extra disease, because we are going to find it in patients with fatty tissue also. And here's just a movie of this particular case, moving it around. Okay. This is a patient with a slowly enlarging left breast with the enhancement, and diffuse enhancement is sort of rounded and somewhat nodular in this patient. The kinetic enhancement in this case was benign, and this is a patient with a big fibroadenolipoma, as opposed to this patient who has a 42-year-old with developing firmness in her breast, and she's got a diffuse enhancing lace-like pattern that we see in invasive lobular carcinoma, linear infiltration through the breast. I'm going to speak on Sunday about how important I think MR is in evaluation of the patient with breast cancer. We're doing almost all of our patients now who are newly diagnosed at the University of Chicago are receiving MR to assess the amount of tumor that actually is present in the breast. And the question we're asking ourselves is, can MR improve the assessment of tumor size, margin, number, and locations of malignancy? The answer to that is almost certainly yes. And I'll just show you one example. Here's a patient from our New York practice, a young patient with a palpable mass in her breast, MR showing the index carcinoma enhancing, and another tumor anteriorly located with respect to it. Here you see it, multiplanar reconstruction. So we directed an appropriate surgery. She had lumpectomy and has done quite well. This is not visible in any other way, so additional cancers are found probably in 25 to 40% of cases. I looked at our data in Chicago and the first 150 cancers we found, and we found extra disease that was not visible even in retrospect with mammography and ultrasound in 29% of our cases. So that is why I think that we need to reconsider and relook at our pre-treatment assessment of disease extent. I'm going to finish here. We were going to be hearing a lot more about breast MR in the rest of the course. I wish you all a very nice evening. Thank you very much.